Hey guys, welcome back. We're going to have a quick discussion on the recall questions from cardiology and nephrology that have been asked in NEET SS 2022. To be fair and straight, the type of question that they've asked in NEET SS 2022 is simple and straightforward. I don't think there are any sort of big ambiguous questions. Maybe I felt some questions are ambiguous that may be related to the quality of recall, but apart from that, the questions that have been asked in exams has been simple and straightforward, and they're expected topics and they're all expected questions, to be honest. And I'll be discussing cardiology and nephrology questions in the next 30-40 minutes. Later on in the next session, I'll be taking up neurology and hematology questions as well. And the session is going to be very short and crisp, around 30 to 40 minutes and nothing more than that. And we'll be discussing around 20 questions from cardiology and around 20 questions from nephrology. Let us move into the session. Yeah, the first question over here. So they've asked about what is the diagnosis of the CCG. It's simple. You have a bifascicular block in the CCG. And in the V1, you are able to see white Pqrs. Along with it, you can see the characteristic M pattern, or you can call it as the RSR or RR pattern. So along with that, you're able to see a kind of a slurred S wave. It's a prominent but a slurred S wave in V5 and V6 that confirms it's a right bundle branch block. And look at what's happening in the inferior leads. In the inferior leads, you're also able to see the characteristic RS pattern. And that also confirms that the patient is probably having a left anterihemi block, further confirmed by looking at the axis of the ECG. So you have a prominent positive complex in lead 1 and you have a prominent negative complex in lead AVF. In such a situation, you need to look at the lead 2. Lead 2 is showing a prominent negative complex, which is very much suggestive of a left axis deviation that confirms the left anterihemi block as well. So the right answer for this question will be option A, that is right bundle branch block, along with that left anterihemi block. Other options are automatically ruled out. And look at this EKG. So what is the ECG? So whether it's 2:1 AV block, or we can call it as a Mobitz 2 with 2:1 block, or it's an atrial fibrillation, or it's a complete heart block, or it's a first degree AV block. If you look at this ECG, definitely the patient is having bradycardia. So look at the number of large boxes. It's almost 7 large boxes. So the heart rate must be hardly around 40-45, nothing more than that. And so if the patient is having a brady, so we have already discussed this algorithm plenty of times. So brady, you have to suspect an AV block. Next step is to look at the P wave. So if the P waves are present, the P waves may be absent, that follows a different step. But if the P waves are present, the next step is to look at the grouped beats, right? So whether the QRS appears to beat in clusters or groups. So if it's there, then you follow a different algorithm, but here in this case the group beats are not there. You don't see any clustering of the QRS complexes. So the next step will be to look at the PR interval. So look at the PR interval here. We want to know whether it is constant or whether it is varying. So whatever PR interval that is seen in this EKG looks fairly constant. There is no change in the PR interval at all. So if it's variable, then the diagnosis probably would have been a complete heart block, but the PR interval is constant over here, so that rules out the possibility of a complete heart block. So next step is to look at the Pqrs ratio. So whether it is in the range of 1:1 or whether it is more than 1:1, that is what we want. So in this example, the Pqrs ratio is definitely more than 1:1. So look at the number of P waves. You have a P wave over here and you have another P wave over here. Okay, but out of 2 P waves, only one is conducted as QRS. So you have 2 P waves, but only one is conducted as QRS. Another P wave is not conducted as QRS. So you have 2 P waves, only one is conducted. Again, you have 2 P waves, only one is conducted. So definitely the PQRS ratio is more than 1:1. That confirms a 2:1 AV block. Or if it's going to be more than that, it will be called as high grade AV block as well. So both are correct. So the right answer for this question is going to be 2:1 AV block. So why not atrial fibrillation? Obviously the rhythm will be irregular and you would not be able to see the P wave at all in the first place. The baseline will be just fibrillating. Why it's not a complete heart block? Because you have some association with the P wave and the QRS. In complete heart block, you're not going to have any association between P wave and the QRS. So that's ruled out as well. In first degree AV block, you're going to have only prolonged PR interval, not a blocked P wave at all. So that rules out the first degree AV block as well. So the right answer for this question will be 2:1 AV block. Simple and straightforward. So question number 3. All of the following regarding the management of patient are true with the below ECG except. So first of all, what is the diagnosis? I think the diagnosis is an inferior wall myocardial infarction. So there's no doubt about that. So you have a patient with ST elevation in leads 2, 3 and AVF, of course. And what is the culprit artery over here? So to find out the culprit artery, look at the ST elevations in lead 3 and lead 2. Definitely the ST elevation in lead 3 is more than lead 2. That confirms the culprit is right coronary artery. And also look at the lead AVL and lead 1, so which is showing more ST depression. So I think AVL is showing more ST depression compared to that of the lead 1. So that also confirms that it's very likely to be a RCA culprit. Whenever there is a RCA culprit, it's possible that the patient can have a right ventricular MI. Even though I cannot confirm with the 12 lead ECG, I need a right-sided lead like V4R to confirm the presence of an associated RVMI, but I cannot rule it out just with the help of a standard 12 lead ECG. Even though in V1, if you're going to see ST elevation, that can be suggestive of a RVMI, that is associated with an inferior MI, but I cannot confirm it unless until do a ECG with a V4R lead. That's a right-sided lead. But nevertheless, in inferior MI, there is a high possibility of an associated RVMI, especially if it's an RCA culprit. So in that situation, you should not give any treatment that's gonna reduce the preload. So aspirin clopidogrel definitely yes, indicated. PCI yes, lysis yes. All of these things can be indicated depending on the time of arrival of the patient. But what you should not do is actually fluid restriction. In fact, in patients with inferior MI and associated RVMI, if the patient is having a pre-shock or a hypotension kind of a situation, and if the JVP is less than your target, that is 10 to 14 millimeters of mercury, it's better to give more IV fluids to maintain the preload, because RV is very preload sensitive. So you should not give any treatment that's going to reduce the preload like nitrates or probably fluid restriction or probably even diuretics in that situation. So that's why the right answer for this question is going to be fluid restriction. And tendinitis and tendon rupture is a potential side effect of which drug? Everyone knows that quinolones are well known for causing tendinitis and tendon rupture. But it's important to understand that statins also can result in development of tendinitis and tendon rupture, as mentioned in the Harrison. Other drugs that have been mentioned are not really associated with tendinitis and tendon ruptures. According to the Harrison statement, quinolones, glucocorticoids, certain retinoids, statins, aromatase inhibitors like anastrozole and collagenase injections may be associated with tendinitis and tendon rupture, but the answer for our question is going to be statins. Very simple, straightforward, no doubt about that. Coming to question number 5. So patient is a known case of hypertension, diabetes, MI, post-stenting is also known case of CKD with EGFR of 58. Already on enalapril, atorvastatin, aspirin, and clopidogrel, which of the following has the most cardioprotective effect? Which means they are trying to ask question on which of the following drugs that's going to reduce major adverse cardiac events, whether it's EMPA or whether it is metformin or pioglitazone or semaglutide. So when it comes to anti-diabetic drugs, we have discussed time and again that only 2 drugs are going to have effect on reducing MACE. One is going to be the SGLT2 inhibitors. Second is going to be the GLP-1 analogs. So in the SGLT2 inhibitors, only 2 drugs have been concretely shown to reduce MACE. One is going to be the EMPA and second is going to be the canagliflozin. Unfortunately, DAPA has not yet been proven to have a concrete evidence with regards to reduction in the MACE. That is in concordance with the trial that was published in NEJM in 2019, which clearly said that DAPA did not show any effect on reducing MACE. Rather, it did have a good effect in reducing the heart failure hospitalization and reducing the cardiovascular death in patients with heart failure. But when it comes to reducing MACE in patients with diabetes without heart failure, so DAPA has not yet been a proven drug in that situation. So either EMPA or CANA will be the answer. And apart from that, when it comes to GLP-1 receptor analogs, only 3 drugs have been shown to reduce MACE. One is going to be the liraglutide, second is going to be the albiglutide, third one is going to be the dulaglutide. Unfortunately, semaglutide has not been shown to reduce MACE in any way. So the right answer for this question is going to be obviously empagliflozin. And you can give empagliflozin if the EGFR is more than 20. Of course, this patient's EGFR is 58, so definitely that makes empagliflozin the choice in this patient that is given in the question. And coming to question number 6, they're asking which of the following clinical finding is most suggestive of severe aortic stenosis. It's not carotid thrill, because carotid thrill may tell you the organicity of AS, in the sense like you can differentiate between aortic sclerosis and aortic stenosis with the help of carotid thrill, where carotid thrill will be present only in AS and not in aortic sclerosis. But it will not tell you the severity. Diamond-shaped murmur again is not going to tell you the severity. Rather, the kite-shaped murmur or the late peaking murmur is going to tell you the severity. The grade of the murmur again is not going to be telling you the severity. In fact, the intensity of any murmur is not going to be proportional to the severity of your valvular heart disease. So that rules out option D as well. And the only option that we are left with is A, that is paradoxical split or single S2. That's correct. Early anacrotic notch along with the narrow split or a single S2 or especially a paradoxical split or reverse splitting of S2 is going to be associated with severe aortic stenosis. The right answer for this question is going to be option A. Coming to question 7, it is very, very simple and straightforward. What is the JEP finding in patients with tricuspid stenosis? The right answer for this question is going to be slow Y descent. That's as easy as it can get. And prominent CV wave you are going to see in patients with severe tricuspid regurgitation, where you are going to have a large V wave, and slow X descent, of course, is not going to be the answer. And what about Canon waves? Canon waves can be regular or irregular. And of course, regular Canon waves will be seen in conditions like AV and RT, which is going to clinically manifest as something called as frog sign. And when it comes to irregular Canon waves, you're going to see in patients with AV dissociation. You know, Brady with AV dissociation is complete heart block, and Tachy with AV dissociation is going to be your ventricular tachycardia. So Canon waves will be seen in a different setting, not in patients with TS. So when it comes to slow Y descent, two causes: tricuspid stenosis and patients with right atrial myxomas. These are two things that you need to remember. So the right answer for this question is option A, slow Y descent. So what about JEP finding in severe TR? That's question number 8. Just a while ago, we discussed that it's going to be CV waves. In patients with severe TR, you're going to have CV waves with a very large V wave or a giant V wave, and there will be absolutely no X descent. It's not slow X descent, it's obliterated or absent X descent. So when it comes to absent X descent, you have only two important causes. One is going to be a severe TR, and second is going to be atrial fibrillation. That's very important for exams. So right answer for this question is going to be CV waves. And clinically, CV waves can manifest as something called as Lancisi sign. So what is Lancisi sign? So you're going to have so prominent CV waves that's going to cause a sort of earlobe pulsation. That's what we call Lancisi sign. And what about Canon waves? We have already discussed the situations we are going to see Canon waves, and I don't think there is any term called a slow X descent. We have a prominent X descent and absent X descent. Prominent X descent is typically seen in the setting of conditions like constrictive pericarditis, and absent X descent is a feature of severe TR or probably atrial fibrillation. And what about rapid Y descent? You're going to see in conditions like your constrictive pericarditis again. So when it comes to rapid Y descent, because in tamponade you see more of a rapid X descent rather than a rapid Y descent. So prominent X descent and prominent and rapid Y descent can be seen in patients with constrictive pericarditis. Especially in constrictive pericarditis, this prominent Y descent is also referred to as something called as Friedrich sign. Which of the following is correct with regards to MR and AS? Eccentric hypertrophy is seen in aortic stenosis is wrong, because in aortic stenosis you have pressure overload situation which is going to produce concentric hypertrophy only. Concentric hypertrophy seen in MR is also wrong, because in MR you're going to see volume overload that is going to typically produce eccentric hypertrophy only. So option B is the right answer for this question. Systolic stress is proportional to LV pressure and ventricular diameter, which is absolutely correct because it is suggestive of something called as Laplace law, so which governs your volume overload and lot of valvular heart disease. And coming to question 10, which of the following is the treatment of acute mountain sickness and high altitude pulmonary edema? So if they ask you prophylaxis for acute mountain sickness, then the easiest choice of answer will be astazolamide. But once you develop complications like high altitude pulmonary edema, astazolamide is not going to be enough for your therapy. So the right answer for this question is going to be nifedipine, which is one of the very, very important drugs in the setting of high altitude pulmonary edema. So the cornerstone of all the problems in patients with mountain sickness and complications of mountain sickness like high altitude pulmonary edema and cerebral edema is going to be low PaO2, that is hypoxemia. That's going to cause a reactive hypoxic pulmonary vasoconstriction that is believed to be the reason for development of pulmonary hypertension, which can be treated with drugs like nifedipine to some extent. But the treatment of choice for any high altitude related problems is going to be rapid descent, as simple as that. So even for conditions like altitude pulmonary edema or even cerebral edema, the treatment of choice will be rapid descent. But in the meanwhile, you can use therapies like oxygen plus or minus nifedipine plus or minus NIV, that is non-invasive ventilation, like CPAP or probably a BPAP. Furosemide has absolutely no role. It's going to cause further problems by causing metabolic alkalosis. Astazolamide, at least to some extent, can produce metabolic acidosis that can be beneficial, but furosemide is not at all going to be beneficial. Diltiazem has a very, very poor vasodilatory effect. It's going to be predominantly an AV nodal blocker and a negative inotropic agent, which can be deleterious in such a situation. And dexamethasone could have been the right answer, probably if the patient is having a high altitude cerebral edema, but in high altitude pulmonary edema, dexamethasone doesn't help. So the right answer for this question is nifedipine. And coming to question 11, asymptomatic female with cyanose blue tongue, what is the cause? So the right answer is excessive nitrates in water that is causing methemoglobinemia. So polycythemia, yes, it can cause cyanosis, in fact frequent cyanosis, but the patient will definitely be symptomatic. In severe anemia, patient will be symptomatic as well. In congenital cyanosis, patient will be symptomatic as well. We're talking about cyanotic congenital heart disease here. So the right answer for this question is option A, excessive nitrates in well water causing methemoglobin, that is causing an asymptomatic cyanosis. And coming to question 12, anticoagulation of choice in patients who are undergoing angioplasty plus HIT, heparin-induced thrombocytopenia. So definitely you cannot use any form of heparin, including enoxaparin, in the setting of HIT. Warfarin cannot be used in angioplasty because oral anticoagulation has absolutely no role in the setting of angioplasty. So it's going to be either bivalent or fondaparinux, so which are absolutely safe in the setting of heparin-induced thrombocytopenia. But I would prefer bivalent because we are talking about angioplasty. In angioplasty, fondaparinux is definitely inferior. It's not going to be able to provide enough anticoagulant cover. So the right answer is bivalent. So when it comes to your acute coronary syndrome and urgent angioplasty, the choice will be either UFH or it's going to be bivalent, depending on whether the patient is having history of HIT or not. When it comes to medically treated ACS, where you are not performing any intervention, only medical treatment, then in that situation, it's going to be either fondaparinux or enoxaparin, depending on not whether the patient is having history of heparin-induced thrombocytopenia. So, of course, it's easy to say that in this patient, the choice will be bivalent or not fondaparinux. So, coming to question 13, least commonly associated with aortic regurgitation. It's not aortic dissection. We know that aortic dissection can be commonly associated with AR, and Marfan syndrome is very commonly associated with aortic regurgitation, and ankylosing spondylitis is also going to be associated with aortic regurgitation. This is because of aortitis, inflammation of the aortic root. In fact, the most common valvular heart disease in patients with ankylosing spondylitis is going to be aortic regurgitation only. The right answer for this question is SLE. Even though SLE can produce aortic regurgitation, it's rare, very, very rare. It's not common. And coming to question 14, you have a young asymptomatic male, no family history of sudden cardiac death, echo and TMT are normal. What is the most likely ECG abnormality? So very likely it has to be a right bundle branch block because the incidence of RBB in a young, healthy, asymptomatic male is approximately 0.5 to 1%. And when it comes to RBB with epsilon wave, it is a finding of arrhythmogenic right ventricular cardiomyopathy where echo will show RBB dysfunction and there will be definite history of sudden cardiac death in the family. Plus, at the same time, patient will be definitely symptomatic. And RBB with estimation V1 to V3 is suggestive of Brugada syndrome. And again, it's very common in males. It's an autosomal dominant condition. It runs through families, so you can expect a family history of SCD. Even though echo may be normal in setting of Brugada, you might expect a family history of sudden cardiac death, and the patients will be symptomatic. Like for example, they can have history of syncope. None of the above is a wrong statement. So the right answer for this question is going to be right bundle branch block. And sine wave appearance is seen in patients with hyperkalemia. This is a no-brainer at SS level. I don't think there is any further discussion that is required. Hypothermia will produce Osborn waves, which is a form of prominent J waves only. And patients can have associated bradycardia, QT prolongation, and ST elevation or J point elevation. And hypocalcemia typically tends to produce prolonged QT interval, especially the ST part will be prolonged rather than the T wave part. When it comes to hypokalemia, you're going to have flattening of T waves. Along with that, ST depression may be there. And along with that, patients can have prominent U waves. And there will be prolonged QU interval. Even though you can call it as prolonged QT interval, but it's more appropriate to call it as prolonged QU interval. Coming to question 16. True statement about ECG. J point elevation can be physiological or pathological. Absolutely right statement. It can be physiological and it can be pathological as well. And prominent U wave is seen in tachycardia. Wrong, because prominent U wave is seen in bradycardia and not tachycardia. And P wave is only due to LA activation. Wrong, because P wave is produced due to both LA as well as RA activation, because a normal P wave contains a left atrial component as well as the right atrial component. T wave is due to atrial depolarization. Wrong, atrial depolarization is going to produce A wave, and T wave is a result of ventricular repolarization. The right answer for this question is option A. MVP is associated with Carpenter classification type. This is something that we have discussed time and again in our heart failure section itself. The right answer for this question is option B. That is Carpenter classification type 2. So what are the different Carpenter types when it comes to MR? Type 1 is somewhere you're going to have a normal leaflet motion, but the MR is going to be due to either annular dilatation that happens in the setting of severe heart failure and LV dilatation, or can be due to perforation that happens in conditions like infective endocarditis. And type 2 is due to excessive leaflet motion, which can be due to a prolapsed leaflet or a flail leaflet, especially in the setting of conditions like mitral valve prolapse. And type 3 is due to restricted leaflet motion, which can be due to thickening or fusion of the leaflets that is going to happen in the setting of conditions like rheumatic heart disease, or it can be due to ischemic LV or LA dilatation, where the papillary muscles and the leaflets will be tethered to the non-contracting left ventricular wall. So the right answer for this question is going to be option B, that is Carpentier type 2. So coming to question 18, Fidget sign is seen in. So to be honest, all of these 4 options can produce Fidget sign, that is relative bradycardia. At SS level, I don't think it's important that we discuss about the definitions of relative bradycardia or Fidget sign, but look at the table from Harrison. Salmonella typhi, that is enteric fever, can produce relative bradycardia. Many atypical infections, including leptospirosis caused by Leptospira interrogans, can produce Fidget sign, relative bradycardia. And many parasitic infections like Babesia and even Plasmodium causing malaria can produce relative bradycardia, and many viral infections including dengue can produce relative bradycardia as well. So all 4 technically, according to literature, can produce relative bradycardia or Fidget sign, but the most right will be enteric fever because it's traditional. That's how we learned, isn't it? And coming to question 19, least common cause of heart block is. So let us look at the Harrison table again. These are the infectious cause of heart block. Endocarditis can produce Lyme's disease, Chagas disease, syphilis, tuberculosis, diphtheria, toxoplasmosis. All of this can produce heart block, but HIV doesn't produce heart block. The right answer for this question is going to be option C. So coming to question 20, true regarding ECG. Hypocalcemia, short QT, wrong, because hypocalcemia is going to produce long QT only. Hypercalcemia, long QT, wrong. Hypercalcemia is going to produce short QT. In fact, hypercalcemia and digoxin are the ones that are associated with short QT. And hypomagnesemia, long QT, correct, and hypermagnesemia, short QT, wrong, because whether any ECG change is associated with hypermagnesemia or not is something that we don't know, but some textbooks say that hypermagnesemia is commonly associated with long QT, but that is something that is questionable and that is not concretely known. According to Harrison, 3 electrolyte abnormalities tend to produce prolonged QT, that is hypokalemia, hypomagnesemia, and hypocalcemia. So the right answer for this question will be option C, that is hypomagnesemia producing long QT. Coming to question number 21, which of the following is a potassium channel blocker that inhibits late sodium current? If this is the exact question, then my choice will be ranolazine, because that's the drug that's going to produce, okay, potassium channel blockade. Along with that, you're going to inhibit the late inward sodium current, otherwise called as INA current. And that is the reason why ranolazine can be associated with slight bit of QT prolongation also, even though that doesn't translate into any risk of arrhythmia like Torsades. And there are some variations with regards to this question, because I don't know the recall quality, but some students say that it's IV potassium channel blocker that was specifically asked. Then in that situation, amiodarone will be the answer, because strodonadrone is definitely not IV. It's an oral drug, and ranolazine is also an oral drug. It's not available IV. So amiodarone will be the choice, because amiodarone is the one that's going to inhibit the sodium current along with inhibition of the potassium channels. And what about ibutylate? Ibutylate is also an IV drug. It's going to block the potassium channels, but it doesn't inhibit the sodium channels. Rather, it's going to cause sodium channel activation. If they are specifically given about the slow sodium channel activation, they're specifically given about slow sodium channel activation, then ibutylate will be the choice. In fact, the most important mechanism of ibutylate is activation of slow sodium channels. That's going to increase the atrial and ventricular refractory period. So that's the most important mechanism of action of ibutylate. Supplementary action is blockade of the potassium channels. So if they have just given about potassium channel blocker with late sodium current inhibition, right answer will be ranolazine. If they have given about an IV drug, then amiodarone will be the choice. If they have used the word sodium channel activation, then probably ibutylate will be the choice. As simple as that. Coming to question 22, I think we are entering the nephrology zone. 17-year-old EGFR dropped to 30 ml per minute per 1.73 meter square body surface area. Urine output reduced to 0.25 ml per kilogram per hour for approximately 24 hours. What is the KDIGO AKA stage? There is nothing called AKA stage 4. It's either stage 1, 2 or 3. So if you look at the KDIGO definition and staging of AKI, you can see if the EGFR has suddenly dropped to a value of less than 35. Okay, so then definitely you can place them under KDIGO stage 3. Accordingly, if you look at your urine output, it's less than 0.3 ml per kilogram per hour for more than 24 hours. Okay, for 24 hours or more. If that is the case, then also you can place the patient under KDIGO stage 3. So the right answer for this question is going to be KDIGO stage 3. And coming to question number 22, a HIV patient presents with edema and frothy urine examination reveals severe proteinuria. What would be expected in the kidney biopsy? And we know that HIV-associated nephropathy is the most common form of kidney injury or glomerular injury when it comes to HIV patients, and characteristically HIV-associated nephropathy will be associated with collapsing type of FSGS. So the right answer for this question is option B. That is straightforward. What is the characteristic feature of a dilysable toxin? A dilysable toxin should have low volume of distribution so that it stays within the plasma compartment, doesn't move elsewhere outside, which is going to render the molecule non-dilysable. It has to have a low molecular weight. High molecular weight substances cannot be dilysed efficiently because dialysis is all about small molecular weight substances. And of course, it has to be water soluble, and the plasma protein binding also has to be low when it comes to dilysable toxins. So the right answer for this question is going to be option C. So coming to question number 24, which of the following is true with regards to prerenal azotemia? When it comes to prerenal azotemia, FeNA will be less than 1%, urine osmolality will be more than 500, not less than 350. Urine creatinine to plasma creatinine ratio will be more than 40, not less than 20. And blood creatinine ratio is going to be more than 20 in the setting of prerenal azotemia and not less than 15. Urine osmolality of less than 350, that is non-concentrated dilute urine, and urine creatinine plasma creatinine ratio of less than 20 and blood creatinine ratio of less than 15 are all features of intrinsic renal leakage, that is acute tubular necrosis, and not prerenal azotemia. The right answer for this question is going to be option A, that is FeNA less than 1%, which is a clear-cut feature of prerenal azotemia. Question number 25. So, patient with E. coli infection, probably UTI, was given gentamicin. That's an aminoglycosid. In fact, it's a toxic aminoglycosid to the kidney. Patient developed hypokalemia, hypocalcemia, and hypomagnesemia, multiple electrolyte disturbance. What is the probable cause? This is something that we have discussed already in our PrepLadder lectures under AK. It's a straightforward statement that I mentioned in one of the PPTs, where aminoglycosides can produce something called as acquired Bartter syndrome. And more importantly, I have also mentioned that aminoglycosides are going to produce a particular type of Bartter called as Bartter type 5, where hypocalcemia is going to be very prominent. Here is a table that I have given for reference about the different types of Bartter. In the type 5 Bartter is basically due to problems of the calcium sensing receptor in the kidneys, and that's going to produce significant degrees of hypocalcemia. But nevertheless, so we are talking about aminoglycosides that can produce acquired type 5 Bartter. That's a straight line from one of our lectures. So definitely the right answer for this question is going to be option C. There's no need to discuss any further with regards to that question. And coming to question 26, all of the following regarding the image are correct except. So you are having a CT image over here that is suggestive of ADPKD, where you are seeing grossly enlarged kidneys with multiple cysts, and they're asking which of the following is wrong. So MVP is an important cause of death is definitely wrong, incorrect, because MVP, even though it's one of the most common cardiac problems that you encounter in the setting of ADPKD, it's not a cause of death. Most of the patients will be asymptomatic and they're not going to experience problems like sudden cardiac death. Option B states young hypertension is uncommon. It's a partially right statement. In most situations in ADPKD, once the creatinine starts elevating, that is, once the GFR starts dropping, hypertension starts. But before that, hypertension is still possible. I'm not saying no, but it's not that common. So that's why option B, I can say it's a partially correct statement. Cycloaneurysm can result in bleeding. Definitely correct, because ADPKD patients are prone to develop berryaneurysms that can result in subarachnoid hemorrhage. That could be the cause of death. And ultrasound can be used for diagnosis. Definitely correct statement, because ultrasound is one of the first line tests. And in fact, some textbooks say it's one of the best tests to diagnose ADPKD. And for screening also, ultrasound is preferred. Genetic testing is preferred only in very rare situations. And the right answer for this question accordingly will be option A. And what about question number 27? So patients are having features of infantile malignant osteopetrosis. That is, the patient is having features of type 3 RTA, multiple calcifications in the head CT, and marble bones in the X-ray. These are the features that are given in the exam question. What is the defect? Defect is carbonic anhydrase type 2. So there are two forms of osteopetrosis that are very, very important. One is the autosomal recessive form that's going to produce infantile malignant osteopetrosis, where the patient will have problems in the kidney like Fanconi syndrome and type 3 RTA, and patients will have multiple calcifications in the head CT and developmental delay because of that. And patients will be having thick cortex in the form of marble bones in the X-ray that can result in bone problems and fractures. So that is the autosomal recessive form. So that is called as infantile malignant osteopetrosis, and the defect here is carbonic anhydrase type 2. And the second form is autosomal dominant type of osteopetrosis that presents a little late, where the patients will have primary bone problems and nothing more than that, and it is because of problems in the chloride channels, especially type 7 chloride channels. These are the two forms of osteopetrosis that you have to know for exams. Apart from that, pyruvate kinase deficiency is going to produce only hemolytic anemia, and methyl tetrahydride folate reductase deficiency is going to affect the folate cycle and the methionine cycle, so that the patient will have developmental delay and they're going to have very high levels of homocysteine because homocysteine cannot be converted to methionine. And pseudo hypoparathyroidism, patients are going to have low calcium plus or minus high phosphorus but a normal or high PTH. Along with it, they will have skeletal problems like Albright's hereditary osteodystrophy, and that is not the case here. So the right answer for this question is option D. ANA testing is least helpful. This is one of the easiest questions in the entire paper. It's simple and straightforward. The answer is rheumatoid arthritis, because here you're going to see either a positive rheumatoid factor and or probably an elevated ACPA, that is anti-citrullinated peptide antibodies. The most common example for that will be anti-CCP, but ANA is rarely positive if at all. All the other three conditions are very well-known causes of positive antinuclear antibodies. And coming to question number 29, you have a young child, maybe around 10 years of age, with sore throat, hematuria and hypertension. Throat swab gram stain culture was negative and C3 was low. So this is a typical picture of a PSGN. So till that, the diagnosis will be a post-infectious glomerulonephritis. But once you make sure that there is some evidence of streptococcal infection like positive ASO titer and or probably positive other titers like anti-DNASP or anti-hyaluronidase or anti-streptokinase, you can make a diagnosis of PSGN. After a couple of weeks, the C3 levels are persistently low, which means you're talking about persistent hypocomplementemia. What is the next best step? Here our diagnosis is PSGN, but we are considering renal biopsy because there is persistent hypocomplementemia. There are very few selected situations where you do renal biopsy in the case of suspected PSGN, like persistent hypocomplementemia or persistent kidney injury in the form of azotemia. Otherwise, we don't really do a renal biopsy. We just treat it conservatively, taking it as PSGN unless proved otherwise. So the right answer for this question is option A. IgA nephropathy is wrong because C3 levels are unlikely to be low in the setting of IgA nephropathy. MPGN can produce low C3 levels, but here our suspicion is not MPGN at all in the first place. And starting prednisone at 1 mg per kilogram per day straight away will be probably appropriate in the setting of suspected minimal chain disease, but apart from that, in the setting of a nephritic syndrome like this, we are not going to start steroids straight away unless until we have a biopsy evidence of something specific. PSGN doesn't have any specific treatment. So steroids will not be given in PSGN. We are going to only treat it supportively. Coming to question 30, it's one of the most easiest questions in the entire paper. Again, all of the following are features of primary hyperaldosteronism, except primary hyperaldosteronism is going to produce hypertension because of excessive sodium reabsorption, metabolic alkalosis and hypocalcemia. Along with it, can produce resistant hypertension and young hypertension also. But what is wrong? Definitely, it's metabolic acidosis. Right answer is option A. It is not a feature of primary hyperaldosteronism. Coming to question 31, it's an ABG based question. Post-op pain and shortness of breath during the post-op day 3. ABG shows a pH of 7.45, which means the patient is having a kind of alkalosis, and PaCO2 is 29, that is decreased, and bicarbonate is 18, which is also decreased. So what is going to correlate to the pH? So bicarbonate of 18 will not correlate to the pH because bicarbonate of 18 should have resulted in acidosis and not alkalotic pH. But PaCO2 of 29 is correlating with the pH, and that is what is the main reason for the alkalosis. So I can say the primary problem is respiratory alkylosis. And look at the base excess. Base excess in a pure respiratory disorder should be normal. Whether it's respiratory acidosis or alkalosis doesn't matter. Base excess will be normal, and the normal base excess is -2 to +2 or probably -3 to +3 according to certain textbooks. A base excess of -5 clearly tells you that the patient is having an associated metabolic acidosis as well. So it's a very, very simple and straightforward diagnosis, that is option C, that the patient is having metabolic acidosis and an associated respiratory alkylosis. If you want to solve just with these three numbers, still it is possible. So look at the patient's pH, it is 7.45, and look at the patient's PaCO2, it is 29. Look at the patient's bicarbonate, it is 18, right? So, and we have already found out that the patient's primary problem is respiratory alkylosis. So in a respiratory alkylosis, whenever the bicarbonate is less than 20, we know that the patient is going to have either a chronic respiratory alkylosis or patient should have a mixed disorder. So in a acute respiratory alkylosis or an isolated acute respiratory alkylosis, the bicarbonate will be usually more than 20, which means it will be either in the range of 20 to 23 or 24. Okay, that's going to be the bicarbonate usually. But if it's less than 20, it's going to be either a chronic respiratory alkalosis or a mixed respiratory alkalosis and a metabolic acidosis. That's the diagnosis. Here it's unlikely to be a chronic respiratory alkalosis just based on the history that's given. So I would recommend the diagnosis of a mixed respiratory alkalosis and metabolic acidosis only. The right answer for this question is option C. Again, straightforward one. And what about question 32? You have a 48-year-old female with long-standing diabetes and diabetic kidney disease with an eGFR of 58. Patient is having hematuria and chronic flank pain and history of frequent urinary tract infection with E. coli. Kidney biopsy shows past positive foamy macrophages and multinucleate giant cells. What is the diagnosis? That's again is a straightforward diagnosis. Answer is xanthogranulomatous pyelonephritis. Okay, genitourinary TB is not the case because clearly the patient is having history of frequent urinary tract infections with E. coli. And in genitourinary TB, you're going to have involvement of the entire urinary tract, and especially you're going to have a characteristic problem called as thimble bladder. That is a small capacity bladder, which is very typical of genitourinary TB, and that's not the case here. Malakoplakia is going to produce the characteristic Michaelis-Guttman bodies and not foamy macrophages or lipid-laden macrophages or multinucleate giant cells. An acute pyelonephritis will have a different picture. So that's not the case here. The right answer for this question is xanthogranulomatous pyelonephritis. Coming to question number 33, you have an 11-year-old child with periorbital and generalized edema. Dipstick shows 3+ proteinuria. What is the most appropriate step? So we know the most common cause of isolated proteinuria with edema in a child is going to be minimal change disease, and you can start with steroid therapy straight away. You can straight away start with prednisolone. Nothing more than that is required. In case if you are experiencing steroid resistance or some problem with steroids like steroid dependency, then you can do biopsy. Otherwise, it's not recommended. Straight away, you can start with steroid therapy. The right answer for this question is going to be option C because your suspicion is going to be minimal change disease. And what is the formula for urinary anion gap? Again, it's a one-liner. The right answer is option A, that is urinary sodium plus potassium minus chloride. Remember, in the blood, the formula for, in the ABG, the formula for anion gap will be sodium minus bicarbonate plus chloride. But the accepted formula for urine anion gap will be urine sodium plus potassium minus urinary chloride, where urinary chloride will be a marker of ammonium excretion. The right answer for this question is option A. Coming to question 35, Liddle syndrome is due to mutation of course, ENaC channels. So it's going to be a gain of function mutation of ENaC channels, and Liddle syndrome is going to be inherited in autosomal dominant fashion. WNK14 mutations will result in activation of sodium chloride transporters. That's going to result in the development of Gordon syndrome. And 11-beta-HSD2 deficiency will result in apparent mineralocorticoid excess, and NK62 defect will result in Bartter syndrome. Okay, so the right answer for this question is going to be option C. Duration of action of insulin in the setting of hyperkalemia is going to be approximately around 4 to 6 hours. 1 to 2 hours probably will be the duration of action of calcium. I'd say 1 to 2 hours for calcium is also too much. It's going to act only for 30 to 60 minutes, and it's not going to have any effect on the serum potassium as such. It's going to only stabilize the membrane. This is about calcium. When I talk about insulin action, it's going to be somewhere around 4 to 6 hours or 5 to 6 hours. That's going to be the right answer. 12 to 24 hours and 24 to 48 hours are wrong statements. So the right answer for this question is option B. Angiokeratoma is characteristic of which of the following disease? Again, it's a straightforward question and you have a straightforward answer. The answer is Fabry's disease. Fabry's disease is going to manifest in the form of a triad where the patient will have skin problems like angiokeratomas, and patients are going to have hypertrophic cardiomyopathy, which can be treated and reversed with fibrazyme, that is galactose beta enzyme. So enzyme replacement therapy can reverse cardiomyopathy to some extent. That's why it's a form of reversible hypertrophic cardiomyopathy. And patients are going to have peripheral neuropathy, and patients can have other problems like nephrotic syndrome also. But this is the typical triad of Fabry's disease. The right answer for this question is going to be option C. And coming to question 38, you have a 45-year-old male who's presenting with polyuria, that is urine output of more than 3 liters per day. And the patient is having a urine osmolality of somewhere around 220 milliosmoles per kilogram. After desmopressin, the urine osmolality increased to 280. What is the possibility? Remember, after desmopressin, if the urine osmolality still remains less than 300, it is nephrogenic diabetes insipidus. If it goes beyond 300, then your diagnosis will be central diabetes insipidus or cranial diabetes insipidus. Because even after desmopressin, your urine osmolality still remains less than 300, my diagnosis will be ADH resistance, that is in the form of nephrogenic diabetes insipidus. And in this situation, you have to see what is the percentage of urine osmolality rise. If it is less than 15% rise after desmopressin from the previous value, it is suggestive of complete nephrogenic diabetes insipidus. If it is in the range of 15 to 50%, it is suggestive of partial nephrogenic diabetes insipidus. You can see that it's increasing from a value of 220 to 280. So it's definitely more than 15%. So the right answer for this question will be partial nephrogenic diabetes insipidus. So option A will be the right answer for this question. Coming to the final question, it's a form of ambiguous question. I don't know what's the exact question over here. So patient is having a diabetic kidney disease. Patient is on telmisartan 40 milligram 2 times a day. Persistent and worsening proteinuria is there in this patient. And what is the next step? So option A states adding ramipril. I don't think that's a sensible choice because ARBs are equally efficacious as that of ACE inhibitors, even though textbooks say first choice is ACE, but both are equally efficacious and both of these drugs should never be added together. Okay, they're only going to increase the risk of side effects without providing any much benefit. Maybe in the setting of IgA nephropathy, some trials have been done where they used combinations of ARBs and ACE inhibitors, but apart from that, it's a common rule that you're not never gonna add ACE inhibitors and ARBs together. So adding ramipril is out of the question. Repeat urine PCR after 3 to 6 months is not going to be of any use, to be honest, because already there is a persistent and worsening proteinuria. And what's the point in repeating urine PCR after 3 to 6 months unless until some new drug is added? So that's not going to be the ideal option. Adding spironolactone will only be a partially correct answer. I would not say it's completely correct, but it can be done according to certain experts, because additional spironolactone on top of ACE inhibitor or ARBs can result in additional antiproteinuric effect. But you have to make sure that the serum potassium is less than 5. To be honest, it should be less than or equal to 4.8 milliequivalents per liter. Along with that, you should have a good EGFR and serum creatinine should be less than 2.5. So then only you can add spironolactone. Otherwise, the risk of hyperkalemia is going to be very, very high, especially if you're going to add it on top of ACE inhibitor or ARBs. Recent studies say that a non-steroidal MRA like findrenone can be added, which has shown promise in the setting of persistent proteinuria on top of ACE inhibitors or ARBs. But again, we have only preliminary studies. We don't have concrete RCTs to substantiate this. But I would say the most appropriate and the most correct option will be to add a SGLT2 inhibitor in this patient, because SGLT2 inhibitors along with your GLP-1 receptor analogs can reduce proteinuria, okay, especially in setting of proteinuric CKD. So these two drugs can reduce proteinuria and can reduce the progression of CKD also. So that's the reason the most appropriate choice will be SGLT2 inhibitors. Maybe if you want to choose a costlier option and in patients with SGLT2 inhibitor contraindications, then GLP-1 receptor analogs will be an ideal choice. But if at all, if I am the examiner, I'm going to give option D, it will be SGLT2 inhibitors, and that will be the right answer in this question. But unless and until I know the option D, I cannot comment on this question. But I would say that adding spironolactone is also an optional step. Other two are grossly wrong. So leave this ambiguous question, and with this I'm going to complete this session and hope you have enjoyed it, and thank you very much. See you soon.